Dear colleagues, ladies and gentlemen, welcome to the view from the Thoraxcenter for Radcliffe Cardiology. This time we are previewing the late-breaking clinical trials for AHA 2024 in Chicago. My name is Nicolas from Mieghem, and as always, next to me, my good friend and colleague, Joost Daemen. Joost, I don't think we will see the premiere of the main outcome of large randomized controlled data at AHA.
No, exactly, you're right. So reviewed the content of AHA this year, and where we've seen quite some interesting stuff passing by in the earlier larger meetings this year. AHA is perhaps somewhat more conservative, a lot of basic science as AHA is known for, a lot of pharma trials, and also quite a lot of trials that actually present secondary outcomes, predefined subgroup analysis and so forth. But we highlight a couple of things that we thought would at least be of interest to the interventional community, and with that, we would like to kick off with the Clear Synergy trial.
And this obviously will be original main outcome, primary outcome data. Right?
Yeah, absolutely. So this is a trial. So we're talking about Clear Synergy, which is a randomized controlled trial from Canada, randomizing over 7,000 patients within 72 hours post-myocardial infarction, being either STEMI or non-STEMI, to colchicine or spironolactone, to demonstrate the cardioprotective effect of both drugs at, I think, 1 year. Interesting because it's more or less a 2x2 factorial design with in principle 4 groups with the different combinations of colchicine and spironolactone. So the primary outcome for the colchicine data will be presented at TCT, but the data for spironolactone will be presented at the AHA. And that is absolutely an important trial, because this trial follows the previous randomized trials on spironolactone, aldactone, finerenone in patients with heart failure and mainly reduced ejection fraction. As you recall, Emphasis was the big important trial that was stopped early due to a massive cardioprotective effect of I think, aldactone. Ephasis was a trial on eplerenone, also demonstrating a cardioprotective effect in patients with reduced ejection fraction post-MI. But this trial doesn't specifically focus on patients with reduced ejection fraction or signs of heart failure, but rather on an all-comer populations of patients presenting with a status within 72 hours post-MI. So that is a little bit, so that is novel, I need to say. And if this trial demonstrates that spironolactone is also showing some cardioprotective effect in a more generic population, that could have important implications on how these drugs are used in a let's say, real-world practice.
And recently at the ESC, we also saw a randomized controlled trial showing positive results with MRA in the context of HFpEF, heart failure with preserved ejection fraction. And obviously, patients with a recent ischemic event, they may have some kind of diastolic dysfunction. So this might become a positive trial.
Yeah, absolutely. And I think that, we will probably dive more into details in the wrap-up, but you know that MRAs are also strong antihypertensive agents, and that may also be a reason to expect a potential benefit in the primary endpoint of CV death, recurrent MI, or new or worsening heart failure.
7,000 patients.
And a significant patient population. Another very big trial that will present, in this case, secondary outcomes is SELECT. So as you recall, SELECT was the large multi-center randomized controlled trial on the cardioprotective effects and morphometric effects of semaglutide, so the Novo Nordisk drug for weight reduction in patients with obesity, demonstrating a 20% reduction in MACE and significant reductions in body weight, waist circumference, etc. A non-diabetic subset was published in Nature earlier this year. And now at AHA, a subgroup will be presented, subgroup analysis on a patient's post-CABG. So I don't know what the exact rationale is to select patients post-CABG. I would have argued that a more generic populations of patients with known coronary artery disease would perhaps have made more sense, but perhaps I'm completely wrong. I haven't seen the exact rationale, but that is something that we will look out for at the AHA to see how this drug will affect patients, at least post-CABG.
Yeah. Well, following up on that is the SUMMIT trial, and the SUMMIT trial focuses on patients with HFpEF and obesity. So it's a randomized double-blind placebo-controlled phase 3 study comparing the efficacy and safety of subcutaneous tirzepatide. And tirzepatide is basically the competitor, if you will, of semaglutide, but it not only contains GLP-1 receptor agonist properties, but it is also an activator of the hormone glucose-dependent insulinotropic polypeptide.
Well, that's a mouthful.
That's a mouthful, but this is quite an interesting trial. So 731 patients will be randomized 1-to-1 to either the study drug tirzepatide or a placebo. Patients are with heart failure, so symptomatic heart failure, HFpEF, so the ejection fraction needs to be above 50%. I think that is important. So we're not looking into the patients with moderately depressed LV function. They had to have an ejection fraction above 50%, and their BMI had to be 30 or higher. The primary endpoint changed from baseline in the KCCQ score, in the KCCQ clinical summary score, and another, the secondary, the co-primary endpoint is the occurrence of the composite of cardiovascular death and or heart failure events. This is an original trial. For the first time, we will see the presentation of the primary outcomes of this trial. But then again, the trial results have already been announced by the sponsor. Eli Lilly already communicated August 1st that tirzepatide reduced the composite of heart failure outcomes that included time to first occurrence of urgent heart failure visit, heart failure hospitalization, oral diuretic intensification, and cardiovascular death. And this was a significant reduction, a relative risk reduction of 38%, which is quite significant. And then on top of that, it also improved the quality of life of these patients at 1 year. What's the novelty then? Well, we will get the nitty-gritty details, I think, of the results. And I do believe that we are definitely witnessing the formal entry now of a drug that really needs to be part of the treatment armamentarium of obese patients.
Yeah, that's obviously the question. I mean, we're talking about a drug. At least if you look for semaglutide, that is now. I mean, the interest worldwide is overwhelming. The effects are overwhelming. But conversely, it's a drug that perhaps partly replaces lifestyle, and that is that's something that a lot of people have difficulties with. Conversely, we know that modification of lifestyle is extremely difficult. So it works, but it's a drug that you need to take it lifelong, and at some point I think the future may be more in agents that have a more genetic RNA, microRNA profiling option to make this a sort of a one-shot lifelong solution. But we'll see. I mean, this is a second drug now that seems to have very positive effects on cardiovascular. Pathologies.
But I think what we're seeing now is that these anti-obesity drugs, they work, and they will reduce cardiovascular events. And whether we do it with a lifestyle modification or with drugs, well, you need to get rid of the obesity. Basically, that is the message. All right. The next study is YELLOW-3. That's also not a novel study.
No, YELLOW-3 is also not a novel study. So YELLOW-3 is actually again a subset, a subgroup analysis of YELLOW-3. It's in this case it's on the transcriptometric signatures and predictors of evolocumab added to maximum statin therapy based on intracoronary plaque characteristics. So basically what this trial is about is to assess the cardioprotective effect of evolocumab in patients that presented with stable coronary artery disease and intermediate coronary artery lesions. So they received evolocumab and got multimodality imaging at baseline and at 26 weeks. The trial already, I think last year, announced its primary endpoint, namely that the addition of evolocumab to a high-intensity statin, so I think that was rosuvastatin 40, was able to further intensify cap thickness. So a cap thickness increased, lipid arc decreased, LCBI scores decreased, plaque burden decreased. So all in line with previous studies like Glagolf and Huygens actually showing the exact same thing. But conversely, and that is, I think, what this presentation will be about, is the fact that there was 24% of the patients in which no reductions in lipid load were observed. And that's quite interesting. That's still 1 out of 4 patients that received quite an expensive drug. And if we could do some genetic profiling to identify these patients, that would be extremely interesting. I'm not sure that is the exact thing the investigators and Annapurna Kearney in this case will present, but I guess it will be about that, and that could be of interest.
Absolutely, absolutely. So there is also a study that would be presented on the treatment of cardiac amyloidosis in patients who also have severe aortic stenosis. Unfortunately, we did not find any more details, but if the treatment of the cardiac amyloidosis with specific oral medical therapy on top of aortic valve replacement would make a clinical difference, that is significant for the community, because I think that the presence of cardiac amyloidosis in the elderly patients that we're treating with for severe aortic stenosis these days, the cardiac amyloidosis is under diagnosed. Yes.
Yeah.
So I'm looking forward to the results of that study. I hope it will be presented. There is another study, not very novel, but at least extending now to 5 years of follow-up. That is the Amplatzer IDE trial, the Amplatzer AMULET IDE trial. We all are familiar with that study because that study has already reported the 1 year and the 3 year clinical outcomes. It is comparing the AMULET LAA occluder versus the Amplatzer, the Amplatzer LAA occluder versus the Watchman occluder. More than 1,800 patients were randomized 1-to-1. And what we know so far is that we don't see major differences in the clinical outcomes, but we already were identifying that the AMULET device might lead to a better closure of the LAA. Now the question is, okay, will that then translate into better clinical outcomes at longer follow-up? I think it's a relevant question, but I do believe, or I have the impression, that the differences in the way the LAA is occluded are so subtle that it won't be of any clinical significance. But let's see.
Yeah, good. Final trial?
Yeah, the VALOR-HCM. This is another trial that we've already discussed previously. It is about the treatment of HOCM patients, hypertrophic obstructive cardiomyopathy, with the specific drug mavacamten. A relatively small study, 112 patients were 1-to-1 randomized, and then the question was, okay, does this drug reduce the need for intervention of septum reduction, so either surgery of alcohol septal ablation, and also what are the effects on LVOT gradients? We already know that out to 1 year, it really was effective in reducing the LVOT gradients, and you also saw that the need for septum reduction decreased from 19% in the control arm to 9% in the treatment arm. Now, how will this result at 2 years? Will we see a further separation of the curves, or will we see a catch-up between 1 and 2 years? That is basically the question that the investigators want to answer at AHA. With that, I think, Joost, this is the end for our preview.
A short preview.
Yeah, will you be at AHA in Chicago this year?
No.
Me neither, but that doesn't prevent us from providing you with a wrap-up. So stay tuned later for the wrap-up of AHA 2024.
Thank you for watching.